Yeah, I know. Time for another Puscast. How can you tolerate the endless excitement that is infectious diseases without putting a massive strain on your heart? This is the intro. You can skip it, but I have things I gotta say because this is CME accredited. This is the Persiflager's Puscast. I'll review the ID literature. This is going to cover the second 2 weeks of January 2011. This is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide, available on the web and as an app. Because this is CME accredited, and when you're done, you can listen to the online quiz and get a half an hour of free CME. Thank you, Legacy Health. I have to mention my potential conflicts of interest. None outside the few shekels I get running this website. Otherwise, I don't have any conflicts of interest. But as I said before, I enjoy reading about war, so I have an interest in conflicts. If you are a new listener, that should give you an idea of what you have to look forward to. A little bit of science, a little feeble joke. Isn't that a song? I don't think so. Also, don't forget to participate in my ever-expanding multimedia empire over at moremark.squarespace.com, where you will find links to my blogs, my podcasts, my electronic books, and my iPhone apps, because the world does indeed need more Mark Crislip. And with that in mind, let's move on to the literature. For those of you who are considering a European vacation, you might want to make sure you get your flu shot before you go. Flu is on the rise in Europe, and it's quite remarkable how many people have died. So far as I write this, actually I'm not writing, am I? I'm speaking. There have been 24 flu deaths in Spain, 11 in the Netherlands, 6 in Ireland, and a whopping 254 people in Great Britain. That's a lot of flu deaths. So don't forget to get your vaccine. The recent study, as I mentioned, in the New England Journal of Medicine in Chinese school children, the H1N1 vaccine was 85% protective from getting H1N1. It's a good vaccine. There is a recurring theme in my podcast. One theme, of course, is infections are bad, but why are infections bad? Besides, obviously, they are an infection. But the inflammatory state that one gets from infection is a prothrombotic state, and that is dangerous for human beings. And there are 2 studies out that help further demonstrate that this month. One looked at pandemic H1N1 flu and the rates of vascular thrombosis. And they found 6% of patients admitted to the hospital with H1N1 had a thrombotic vascular event. Well, that was during acute influenza. Now, several infectious diseases like pneumonia and cystitis can increase the rates of thrombotic events up to a year after acute infections. And perhaps one of the benefits of getting the flu vaccine is not only that you don't get flu, which is nice, but you don't get vascular complications of flu. There was a report last month about how getting the pneumococcal vaccine and the influenza vaccine decreased vascular events, specifically myocardial infarctions in patients for over a year. Well, there's a similar study out this month in the journal Vaccine that looked at the rates of myocardial infarction in patients who got the flu vaccine. Now, these epidemiologic studies are always fraught with potential bias and error because they're not randomized controlled trials. However, they found that patients who got the flu vaccine were less likely to have an acute myocardial infarction, maybe because they are less likely to have a thrombotic event. So there are lots of benefits to getting the flu vaccine, but one of them may very well be that not only will you less likely get the flu, but you're going to have less of an inflammatory response, or if you don't get the flu at all, no inflammatory response, and subsequently have less chances of having a stroke or a heart attack or something like that. Vaccine's good. Infection's bad. Remember that. Turn your head and cough. Well, why does the patient turn their head? Well, it's not to make the hernia come out better. It's so that the patient doesn't cough on you. This comes from the years when tuberculosis was much more endemic. But patients who have an influenza-like illness, i.e. a coughing illness, are potentially communicable. They are communicable from healthcare worker to patient, and they are communicable from patient to healthcare worker. Well, this was looked at in a study in the Annals, actually the Archives of Internal Medicine this year, and they looked at the person-to-person transmission of influenza-like illnesses in a hospital. And they did it over 3 flu seasons. And they found, and I'll read the results here. Here's a quote. For patients exposed to at least one contagious healthcare worker, compared with those with no hospital exposure, the relative risk of a hospital-acquired influenza-like illness was 5.48. If a patient was exposed to a contagious patient, the relative risk was 18%. And for patients exposed to one contagious patient and one contagious healthcare worker, boy, that must be a fun hospital to be in, the relative risk was 35%. Why do illnesses cause you to cough? They do it to spread. I mean, seriously, not wearing a mask around a coughing patient, or even if you're coughing, is like knowing that your partner has gonorrhea and not wearing a condom. It's just stupid. As I have said many times before, unlike love, herpes is forever. Most people who have herpes simplex are not having active lesions, yet they continue to excrete the virus for prolonged periods of time. How long is prolonged? Well, this study looked at HSV-2 shedding after the first clinical episode. So these are people who actually had genital lesions, which is a minority of patients with herpes. And they found that the further out from their initial clinical case of herpes, the less they shed HSV, but they still did. How much, you ask? Well, let's quote the abstract from Clinical Infectious Diseases. Quote, total HSV shedding occurred on 33.6% of days in participants less than 1 year, 20% of those who had their herpes 1 to 9 years ago, and 16% of days in those who are 10 years out from their first episode. Subclinical HSV shedding occurred on 26% of the days among participants less than a year, 13% of those 1 to 9 years, and 9% of those greater than 10 years from their first episode. So, if you've had herpes once, you're probably at some point going to be shedding the virus in the future. Yet another reason to recommend condoms, since you really never know the provenance of another person's genitals. There was an outbreak of plague in China, and it's just kind of wild in how it started. A herdsman lost one of his dogs. He found it 6 kilometers away beside a river, lying there short of breath. He took it home, and the dog coughed and vomited severely with blood in its mouth, and it died 2 days later. The herdsman carried the dead dog on his shoulders, around his neck, down the hill to bury the animal. The patient, or the herdsman, then came down with bubonic plague. He then passed it on to 11 other contacts, 3 of whom unfortunately died, giving you the importance of not wearing your dog. But get this, I just have to quote to you from the article. A doctor who had some knowledge of plague, and when he heard the herdsman's sudden death, he was worried that he had contracted contagious plague. When he developed sudden fever, chest pain, and cough with bloody sputum, he asked his wife not to contact him face to face and to sleep with him in a head-to-foot manner. When he took a bus to Xinghai Prefecture Hospital for further treatment, he put a jacket over his head all the way. He did not contaminate anyone else. Another patient became infected, and they were met by the quarantine personnel and assisted to the hospital. The patient was treated timely in open air on the grassland for 6 hours with transfusion of antibiotics before he was transferred to the hospital. And because he was treated in the open-air grasslands, he too did not infect anyone else. The take-home message, though, is that the dog was the source of pneumonic plague to the human, who then subsequently infected other humans. If you find your dog coughing up blood, keep your distance. And again, don't wear your dog like a fur collar after it dies. But probably most importantly, which I talked about earlier, coughing is how infections are spread. If someone's coughing, don't suck their air into your face. Big duh there. Non-gonococcal urethritis is a pain, both diagnostically and therapeutically. This study evaluated the addition of an anti-trichomonas agent in the treatment of non-gonococcal urethritis and found that it did not increase the cure rates. But it was interesting nonetheless, other things found. 43% of non-gonococcal urethritis was due to Chlamydia trachomatis. 31% was due to Mycoplasma genitalium, and 13% was due to Trichomonas. Now, they found that the cure rates were the same whether or not they got treated with azithromycin or with doxycycline, but, quote, the chlamydia clearance rate was 95% for the doxycycline arm and 77% for the azithromycin arm. So doxy is better for chlamydia. In the mycoplasma patients, those who received azithromycin had a 67% clearance rate versus 31% for those that got doxycycline. So that for Mycoplasma genitalium, azithromycin was the superior agent. And as I said, the addition of tinidazole did not increase the cure rates, but did eradicate trichomonas. As is so often the case in this disease, 30% of patients had no etiology for their non-gonococcal urethritis. And one would wonder, if you've ruled out chlamydia and gonorrhea, if you should treat them with azithromycin, since it was better for the eradication of mycoplasm, and then give doxy for those in whom you confirm chlamydia. All drugs are not equal in the treatment of non-gonococcal urethritis. When you're an intern, it's the don't just stand there, do something that drives patient care. When you become an old geezer like myself, it's more don't just do something, stand there. This is confirmed in a study in clinical infectious diseases in children who had non-tuberculous mycobacterial cervical-facial lymphadenitis. Now, I don't usually report studies on kids because, well, I may act like a child, but I don't treat them. You have to be old enough to, well, not drink. What can you do at 18? Smoke? Be drafted? What's the other one? Oh, yeah, vote. My son's interested in some of those, so he lets me know what he can do now that he's about to be 18. But you have to be 18 or above before you're my patient. But I think it's interesting is they had 50 kids with non-tuberculous mycobacteria cervical-facial lymphadenitis, and they were randomized to get either clarithromycin or nothing. This study was done in the Netherlands, where I guess they don't have malpractice lawyers, and they found there was no difference in the time to resolution, which was 36 weeks in the treated group and 40 weeks in the wait-and-see group. So those who had antibiotics also had GI complaints, fever, and reversible extrinsic tooth discoloration. So it would appear that if you have non-tuberculous mycobacteria cervical-facial lymphadenitis and you get nothing done, you will get better just as fast if you get therapy or not. Now, if you're interested, the organisms they had in this series were M. avium, 76%, M. haemophilum, 16%, M. xenopi, 1 in the wait-and-see group, M. canzaceae, 1 in the antibiotic group, and M. scrofulatum, 1 in the antibiotic group. So it was a hodgepodge of mycobacterium with avium and haemophilum predominating in this population. And whether they got clarithromycin or not, they got better pretty much at 40 weeks. One of my colleagues does an impression of me as a senile old nursing home patient. sitting in a wheelchair slapping my thigh saying, "Drain the pus, drain the pus, drain the pus." David thinks that's how I'm going to be someday, as if I'm not that way already. Undrained pus never heals, and if you want to get pus better, you got to get it out. How? This was an interesting study that compared needle aspiration of a skin abscess to an IND, and the needle aspiration was miserable. Overall, the failure of incision and drainage was 20%, compared with 74% for needle aspiration. If you're going to drain a boil, a pus, you can't stick a needle in it. You got to get a pointy scalpel, numb it up, and make an incision. And that is how you make a boil better. Unfortunately, in my hospitals, we've pretty much gotten rid of a lot of the catheter-related infections. I say unfortunately because, of course, I make a living taking care of patients with infection. But this study in the New England Journal of Medicine looked at heparin versus recombinant TPA for the prevention of catheter malfunction and to prevent catheter bacteremias. And they found that the use of our TPA was superior to thrice-weekly heparin. In those that had the TPA, they had half the catheter malfunction rates and a third the infection rates, which is pretty good. So I suppose, though more pricey, that our TPA is better than heparin in preventing the catheter malfunctions and bacteremia. Yet another study to whittle away at my practice. Soon I'll be standing on the freeway off-ramp. We'll do infectious diseases for food. About, a year ago, there was a study that showed that prophylactic antibiotics during dental work doesn't prevent hip infections, so probably an unneeded intervention. Evidently, it's widely recommended that patients with central venous catheters take antibiotic prophylaxis for dental procedures. So the people in the American Journal of Medicine did a systematic review to determine the level of evidence to support this practice, and they found somewhere between a diddly squat and nada. They found no clinical trials and no documented cases of a catheter-related infection associated with a dental procedure. There's nothing out there, yet there are many recommendations and guidelines that suggest administration of dental prophylaxis under these circumstances. This is the second time I'm going to say this today, but those guidelines would be stupid. I got two stupids. I wonder if I'm going to get a third. Probably. I'll work on it. So the headline is dramatic. The headline says, Pneumonia Guideline Compliance Associated with Increased Mortality. Holy shit. This was published in the Lancet Infectious Diseases. And what they did was they compared patients with hospital-acquired pneumonia. So that's an important caveat there, since most studies show that adhering to the guidelines increases your survival, not decreases it. But that's for community-acquired pneumonia. So I think it's important to note, if you read that headline, this is for hospital-acquired pneumonia. Patients were considered compliant with guidelines if they had a double gram-negative therapy. This was usually either a cephalosporin or a carbapenem, plus an aminoglycoside or quinolone, and in some cases colistin if you had a lot of Acinetobacter, and gram-positive coverage with either linezolid or vancomycin. Now, the non-compliant group was those who did not give a second gram-negative drug, which accounted for 154 of the patients, and failure to empirically treat MRSA, 24 patients. And against the odds, those who did not follow compliance had less mortality. And I'm not certain I believe the study, even though that's the result, and would wonder if there's some fluke, given this was not a prospective study, but a retrospective study. Even when they factored in severity of illness, those that had guideline-based therapy had higher mortality rates than non-guideline-based therapy, again for hospital-acquired pneumonia. I just can't see how this could be the case from a pathophysiologic point of view. They hypothesized that maybe patients were having colistin, aminoglycoside, or quinolone-related toxicities that increased their mortality rate. I don't buy that either. Something tells me my clinical gestalt is this will not be found in subsequent trials. And at least my understanding as to why you give combination antibiotics in patients who are at risk for resistant organisms is that if you give a drug and the organism is resistant, mortality goes up dramatically. The reason you give multiple drugs is to CYA, cover your ass. In case it happens to be resistant to one of the agents, odds are it won't be resistant to both. And if you delay therapy, multiple studies have shown increased mortality rate. So you give multiple drugs up front while waiting culture and susceptibility to see if your organism is indeed susceptible to the therapy you give. Then you can always back off or, in the parlance of the day, de-escalate. This is why this study doesn't make any sense to me, in that if the organisms are resistant to one of your two agents, your mortality rate should go off the wall. So my clinical gestalt is that this study does not make sense, and it's probably going to be a fluke that will not be supported by randomized prospective trials, which are certainly needed now to confirm or deny this particular study. We all know, however, if you're a connoisseur of the legitimacy of the medical literature, that often early studies, which are usually not randomized, prospective, large institutional placebo-controlled trials, are frequently wrong. And I bet you this one is too. And now we move on to the hodgepodge part of the Puscast, where I just give things for which there are no references on the website. But that's why God gave us the Googles. There's a study in the Canadian literature that looked at the combination of erythromycin or clarithromycin with calcium channel blockers and find that there was an association with patients presenting with hypotension and shock, probably because these drugs are inhibiting the cytochrome P450 system and screwing with the calcium channel blocking levels. So be wary of giving macrolides to patients with calcium channel blockers. There is, you will be happy to hear, a new drug for head lice. It's called Spinosad, S-P-I-N-O-S-A-D, and it's just been approved by the FDA, and will probably be more popular with the girls than having their heads shaved. If you're treating pyrimethamine-resistant Plasmodium vivax, there's a drug that's highly effective, and it's, well, I should say highly potent, methotrexate. So I guess when it mutates the active site for the pyrimethamine, it makes it more like human, and the methotrexate is effective. It will also take care of any Plasmodium vivax that has rheumatoid arthritis. So you got a female that has Candida. Is she getting it from her man? Well, the answer would probably be no, based upon this study, where they did typings of the Candida both on men and in women who had symptomatic Candida and found it was extremely rare for them to have the same Candida. So it is unlikely that treating the male partner will help treat the female's candidiasis. So, which is better for the diabetic foot osteodiagnosis, histology or microbiology? Now, this study looked at this issue with 44 specimens and found that a positive microbiology was just as good as a positive histology for finding osteomyelitis in a diabetic foot. And so probably you should not rely upon the histology to rule out the disease. For those of you who like black and red pepper, well, the salami products that have this have been associated with the spread of Salmonella Montevideo. Salmonella Montevideo is the old-fashioned form of Salmonella. Those of us who are into modernity use Salmonella Monte M4A. There's an encoding joke there for you. But still, yet another source of Salmonella. This was a study that looked at procalcitonin in almost 760 patients and whether or not they had endocarditis, and found that a lower procalcitonin made it unlikely that they had infective endocarditis. However, the difference between those who did have it and those who didn't have it was small. The procalcitonin in those who did have endocarditis was 0.21. It was 0.13 in those who didn't. I had a patient recently who I worried about whether or not they had endocarditis, who had a very insignificant procalcitonin. So I, on the basis of this and multiple other clinical indications, felt he did not have endocarditis. Not unsurprisingly, there's a patient in Cleveland who is on long-term linezolid and developed cystic fibrosis. What amazes me is you could treat anybody with long-term linezolid. I can't get anybody past 2 weeks without them getting toxic in one way or another. And, of course, it's expensive. But again, if you put patients on long-term antibiotics, don't be surprised if you develop resistance to that antibiotic. And don't forget, there's a case report and a review of the literature on eosinophilic pneumonia with daptomycin. I have yet to have a case, but there's increasing case reports. So amongst the other things to watch for in patients on daptomycin is eosinophilic pneumonia. I don't know if I can pronounce this, but it's natalizumab. It's a monoclonal antibody used for the treatment of multiple sclerosis and Crohn's disease. It has quite a lot of PML associated with it. In the first year of use, it's 1 per 1,000 patients. After 2 years, it's 2 per 1,000 patients. So PML is a common complication of this particular monoclonal antibody. Of course, what we need is a way to determine those who have JC virus ahead of time, because those are the people who are going to develop PML on the medication. Those studies have yet to be done. Now, when I think of a unilateral visual loss, I usually think of a stroke, but there's a case report of somebody manifesting their neurosyphilis as a unilateral visual loss. So keep syphilis in mind, no pun intended. Listeria can target the heart. There's some variants of Listeria monocytogenes that are specifically good at invading heart tissue, dissolving it, and killing the patient. What to do about it? Uncertain, but it is of interest. There was a patient in Scotland who developed septicemic anthrax from heroin. And they think his heroin, which came from Afghanistan, was contaminated with anthrax, and he got anthrax. So, besides bongo drums and bioterrorism, think heroin as a source for anthrax. As I've said before, I don't think heroin use is a healthy lifestyle. Now, I was always told that patients who had cancer were more likely to get shingles, but that the converse wasn't true, that patients who had shingles were not more likely to have cancer. This study specifically looked at the incidence of cancer in patients with herpes zoster ophthalmologicus. I love ophthalmology literature. I never know where to put the P in ophthalmology. But they found that patients who had herpes zoster ophthalmologicus may have an increased risk of cancer in the following year. They found a rate of 4.8% in patients with zoster versus 0.53% in them what didn't. So in fact, it may be a marker of an underlying malignancy. HIV patients are seeing more and more strokes, and their risks have gone up 60% in some places like Spain. Again, I keep getting back to the fact that having a chronic infection is a pro-inflammatory state, which is a pro-thrombotic state, and you see this in many areas, and HIV is on the list. Now, you can treat hepatitis delta, according to a New England Journal trial, with peg interferon and adofovir, and about a quarter of patients will respond and get rid of their hepatitis D. Now, I've talked in the past about mannose-binding lectin and how it's an important non-specific binder to pathogen sugars to inactivate a variety of encapsulated and other organisms, and the patients with low mannose-binding lectin levels are at increased risk for a variety of infections. Now, this was a mouse model, but what they did in the mouse model is they gave the mice intravenous mannose-binding lectin to get the levels up about 7 times that of average human levels, and they prevented them from dying from Ebola. Now, one would wonder if this could be a therapy for other viruses as well, that you could use mannose-binding lectin to bind the sugars on a variety of viruses to alter their clinical course. I'm sure this will be an area of lots of future research. I've always wondered why they stop valganciclovir in transplant patients, since once you stop it, their rates of CMV start to go up. And usually they give it for about 100 days. If I ever get a kidney transplant, I'm going to take my valganciclovir forever. But they did a cost-benefit analysis in the journal Transplantation and found it to be cost-effective to go 200 days instead of 100 days. They gave a cost-effectiveness ratio per quality-adjusted year of life of $15,000, which is reasonable in the United States, where $50,000 is usually the cutoff that we're willing to spend on people to call it worth the quality of life. So perhaps patients should get longer than 100 days of valganciclovir to prevent their CMV from recurring. It turns out in this study, speaking of CMV, they estimate that a quarter of congenital CMV are due to acute infections in the mother, and 3/4 are attributable to non-primary maternal infections. There was a recent study that showed that non-primary disease and excretion of CMV is common in young women, putting their infants at risk for developing congenital CMV, which evidently is the number one cause of developmental disabilities due to infections in the United States. What to do about it is problematic. As they say, effective prevention studies need to be developed for both primary and non-primary maternal infections. The recent flu vaccine has seen a slight increase in febrile seizures in children who get the vaccine. They do not mention numbers in this report, so I do not know how much the febrile seizure rates went up. Because febrile seizures are self-limited and cause no long-term harm to the child, although they do freak out the parents. They'd freak me out if my kid had one. The CDC and the FDA has not altered their suggestion that everybody on the planet get a damn flu vaccine. Speaking of flu, and I did not know this. It's amazing how much I don't know. I mean, the definition of a specialist is someone who knows more and more about less and less until he knows everything about nothing. I feel like I know less and less about more and more until I'm going to know nothing about everything. But it turns out that with influenza, that patients often have more than one circulating strain of flu when they get an infection. And in this study, they did deep sequencing, which sounds like something out of the Hitchhiker's Guide. And they found a patient who had 3 separate types of influenza H1N1, and that one of the strains had pre-existing oseltamivir resistance, and they developed a more resistant strain as they got therapy. I think it's interesting that, and did not know, that patients are often infected with multiple strains of influenza A or influenza B at a given time. They were all H1N1, but they were different and they can swap their genes, and this will help the organism evolve away from being effectively treated. And look at that, we're at 33 minutes. I try and keep this to half an hour, so I think it's time to stop the hodgepodge and do my usual sign out. So, we've reached the end of the Persiflager's Puscast, a review of the ID literature, little commentary, little references, usual stuff. It's CME accredited. Thank you, Legacy Health. Now that you've listened to this half an hour of inane babbling, take the online quiz and get a free half an hour of CME. This is brought to you by Pusware LLC, publisher of the Persiflager's Annotated Compendium. Actually, it's not called that. It's the Infectious Disease Compendium, a Persiflager's Guide, your uber hyperlinked electronic guide to infectious diseases. It, along with the rest of my growing multimedia empire, because the world does need more Mark Crislip, can be found at moremark.squarespace.com, where you will find my blogs, my podcasts, my iPhone apps, my book. Yes, I have a book. I took the first year's worth of infectious disease blogs, rewrote them, expanded them, got rid of all the typos, hardy har har, and released it as like a 260-page ebook for a mere $5. You can read it on your Kindle, on your iPhone, on your iPad, on any computer. Find links to the Kindle or to the other versions at my website as well. My God, there's so much of me out there, it just makes my teeth hurt. As always, this is copyright 2011 under the Creative Commons license. The music is with my son when he was 12, improvising on the guitar. Email me, but I'll probably never answer it. I'm lazy as hell when it comes to email. I'm such a slow writer. I just look at the email and think, I don't want to do this. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.